Hello, today we are going to complete our discussion of the different cardiac arrhythmias, and we're going to discuss ventricular flutter. Ventricular flutter is a condition where you have fewer S complexes that are bizarre shaped. They all look like each other, but they are not the regular QRS complexes that we usually see in normal sinus rhythm, for example. And they look like sinusoidal waves, as you see. So you cannot determine the Q wave, neither the Q wave nor the R wave nor the S wave. And the rate is very rapid. The ventricular rate is very rapid, ranging between 250 to 300 beats per minute. Usually, ventricular arrhythmias have an underlying pathology of the heart, and the most common cause is coronary artery disease or ischemic heart diseases, where the coronary arteries are relatively narrow, or there is relative deficiency of the blood supply that reaches the myocardium. Forced ventricular flutter is a serious condition because the problem is in the ventricles themselves. When the ventricles themselves are beating at a rapid rate, then there is no protection, and this rapid rate will result in hemodynamic inefficiency. Hemodynamic inefficiency means that the ventricles, since the ventricles are beating very rapidly, then we have a rapid ventricular rate. Then we will have a shorter systole, as we said before, a shorter systole and a shorter diastole. But the cardiac phase that will be affected more is the diastole or the diastolic phase. And the diastolic phase is important because it is the filling phase. So the ventricles do not fill adequately, do not have enough time to fill, and this results in hemodynamic compromise, where the patient will have lower blood pressure and will suffer from all the consequences of a lower blood pressure. So you will find that the patient is pale, you will find that the patient suffers from dyspnea because there isn't enough oxygen that reaches the tissues. The patient might also suffer from headache because of the same reason. The patient might faint, for example, or even lose consciousness. In ventricular fibrillation, the condition is still more serious because we have an ectopic focus, an abnormal focus, whose origin is in the ventricles. And this abnormal focus beats at a very rapid rate that is usually around 300 beats per minute, meaning that it is almost the same rate as that of the ventricular flutter. But why is ventricular fibrillation more serious? Because of the irregular rhythm. When in ventricular flutter, the problem was only that the rate was rapid and that the ventricles were not having enough time to fill, but the contraction of the ventricles was efficient. In case of ventricular fibrillation, the ventricles are beating at a very irregular rate, and from there comes the word fibrillation. And this results in very inefficient contractions of the myocardium, and therefore the pumping action of the heart is affected, and this leads to severe drop in the blood pressure of the patient and might result in death. So you have an irregular rate, you have abnormal QRS complexes, they have an abnormal shape, an abnormal duration, an abnormal amplitude, and they are not similar to each other. In ventricular flutter, the rate was regular, the rate was the QRS complexes, or the electrical activity of the ventricles was more or less similar. It's true that it is not the regular QRS complex that we are used to, but they're all similar to each other here. Even the waves of electrical activity of the ventricles, not only are they irregular, but they are not similar to each other. There is inefficient contraction of the ventricular myocardium, and therefore there is hypotension and maybe collapse because of the hypotension and because blood, oxygen, and nutrients are not reaching the brain. Of course, if untreated, if the patient is not referred to an intensive care unit, then it would be lethal. Of course, this is the most fatal cardiac arrhythmia that human beings can suffer from. In the AV nodal rhythm, as its name indicates, the ectopic focus is in the AV node itself. And because the AV node has a lower intrinsic rate, and when we talk about an intrinsic rate, we mean its inherent rate, the rate that is not driven by, inherent, the rate that is not driven by the sinoatrial node. So the AV node has its own intrinsic rate, or has its own inherent rate, meaning that if the pacemaker, if the SA node is healthy, it would drive the AV node to beat at the same rate as that of the normal pacemaker of the heart, which is the SA node. But if the SA node is already diseased and has a lower intrinsic rate, then at that time the AV node might take over and become the pacemaker of the heart. Although the AV node is not the normal pacemaker of the heart or the standard pacemaker of the heart, yet it fires or depolarizes regularly. So any rhythm that will arise from the AV node will be regular. But the problem with the electrical activity that results from the AV node, if we imagine that the AV, or if we assume that the AV node is present here at the upper part of the interventricular septum, and that this is the atrial myocardium, then the AV node would fire both upwards towards the atria and downwards towards the ventricles at a slower rate than that of the SA node. That's why the waves of depolarization of the atria, which are the P waves, will be inverted, because the direction of spread of impulses is from below upwards. This is contrary to what usually occurs if the SA node is the pacemaker of the heart, where the wave of depolarization will spread from above downwards. That's why we see P waves that are inverted. So first of all, you have a slower rhythm, and it's obvious here that if you, for example, consider those two RR complexes or RR peaks, then you can find that you have 1, 2, 3, 4, 5, 6, almost 7 big squares in between the two RR complex RR points or peaks. So if you divide 300 by 7, then it's about 45 beats per minute, which means that we have a slower than normal heart rate, or we have what we call bradycardia. So first of all, we have bradycardia. Second, it's a regular bradycardia because the AV nodal rhythm is regular. Third, we have inverted P waves because the wave of depolarization arises from the bottom of the atrial musculature from the AV node. But the QRS complexes are normal in shape because they receive the wave of depolarization from the AV node in the normal direction. Usually, every QRS complex is preceded by a P wave because the depolarization of the atria occurs slightly before that of the ventricles because of the close proximity of the atria to the AV node. So usually we find one QRS complex that follows one P wave, but sometimes, of course, there would be overlap if the AV node sends to the atria and to the ventricles at the same time, but this condition will not be studied within this course. By having finished the AV nodal rhythm, then we would have finished the arrhythmias, but I forgot to tell you that the PR interval is most of the time missing because the PR interval is the time needed for the electrical impulse to move from the atria to the ventricles. But here we don't have this time period because the AV node is sending impulses to the atria and to the ventricles almost at the same time with a very short interval in between them. So the PR interval is very shortened or even absent. Now we're going to study the valvular diseases, and I think we did this last year a bit superficially. And we're going to start by mitral stenosis. Mitral stenosis is a condition, as you know, in which there is stenosis or narrowing of the mitral valve that separates the left atrium from the left ventricle. So if this is the left atrium, and that is the left ventricle, then if the mitral valve is stenotic, if you have a stenotic mitral valve, then there will be difficulty for the blood passing from the left atrium to the left ventricle. So the blood will pass through a narrow diameter, and that's why you will hear a murmur. What is the timing of this stenotic mitral murmur? It is a diastolic murmur. It is a diastolic murmur because blood passes from the left atrium to the left ventricle during diastole. So if I ever ask you, why is the murmur diastolic? Because we hear the murmur when blood passes through the mitral valve. And the blood passes through the mitral valve when the mitral valve is open during relaxation of the left ventricle. This means if you have the first heart sound that is due to closure of the atrioventricular valves, and then you have S2 that is due to closure of the semilunar valve, and then you have another S1 and so on, then you all know that after closure of the atrioventricular valve, the ventricles start to contract. And this period between S1 and S2 will be the systole, or the period during which the ventricles are contracting. And then the S2, or the second heart sound, is due to closure of the semilunar valves to prevent regurgitation of blood. And regurgitation of blood is prevented because the ventricles start their diastole. So between S2 and the next S1 or the following S1, we will have diastole. So in case of mitral stenosis, the audiogram would be like this. We have S1 and then S2. We don't have any abnormal murmur between S1 and S2, but between S2 and the following S1, we will hear an abnormal murmur that is a diastolic murmur, and that has a very characteristic nature. It's called rumbling murmur because it's like, when you hear it once, you will never forget it, and it is during diastole. So you hear lub-dub, and then during the longer diastole, you will hear that sound. Of course, especially at the beginning, you have to be in a very quiet atmosphere when you auscultate the heart. This is number one. Number two, you have to be used to the normal heart sounds, because if you don't know what the normal is, then you will not detect the abnormality. And the murmur, as you know, is best heard over the mitral area, which is the fifth intercostal in the fifth intercostal space, left mid-clavicular line. And then we have another murmur that is due to mitral regurgitation, and this results when the mitral valve is wider than normal and incompetent, meaning that when it closes at the beginning of ventricular systole, it does not close perfectly. So when the ventricle contracts in order to pump blood into the aorta, there is generation of high pressure inside the left ventricle. So if this valve, which is the mitral valve, is not perfectly closed, then there will be regurgitation of blood, meaning that there will be backflow of blood from the left ventricle to the left atrium, and this, of course, will diminish the efficiency of blood flow in the aorta. Diminish blood flow in the aorta. What would the murmur, where would the murmur be located? It would be located during systole, because it occurs during ventricular systole. And I mean located on the audio diagram or on the audiogram. So here we have S1, there we have S2, and then the next S1. Notice that the diastolic period is longer than the systolic period, and the murmur will be the murmur of mitral regurgitation, will be a systolic murmur because it occurs during left ventricular contraction. Tricuspid stenosis has the same characteristic as mitral stenosis, meaning that blood will flow during diastole, and if the tricuspid valve is stenotic, then the blood flowing from the right atrium to the right ventricle will flow through a narrow valve or a stenotic valve. So you will have turbulent blood flow because of the narrow orifice or opening, and therefore you will hear a murmur, and that murmur will occur during filling of the right ventricles by the blood that comes from the right atrium. So again, it would be a diastolic murmur. So what's the difference between the murmur of tricuspid stenosis and that of mitral stenosis? If both of them are diastolic, the difference is in where you would best hear the murmur. In case of tricuspid stenosis, of course, you would hear the murmur better or best in the tricuspid area to the left edge of the sternal border, fifth intercostal space. Similarly, tricuspid incompetence, as you see here, will result in regurgitation of blood from the right ventricle that lies here to the right atrium because of the incompetent tricuspid valve. So while the right ventricle is sending the blood or pumping blood into the pulmonary artery, we will have a percentage of this blood that regurgitates or backflows into the right atrium, which of course diminishes the volume of blood that is pumped into the pulmonary artery and therefore into the lungs, and therefore this diminishes the efficiency of exchange of gases in the lungs, since you're sending less blood to the lungs. That's why the patient again will suffer from symptoms of hypoxia, because not enough blood reaches the lungs to be unloaded from carbon dioxide and reloaded with oxygen. So in all the previous examples, the patients will suffer from symptoms of hypoxia, like fatigue, like headache, like dyspnea, whether you have rapid breathing or shallow, rapid deep breathing or rapid shallow breathing. The murmur, just like in mitral incompetence, will be a systolic murmur, because it will be heard only during right ventricular systole, but it would be best heard over the tricuspid area. In case of aortic stenosis, you will have the left ventricle trying to pump the blood into the aorta, but the problem is that the aortic valve will be stenotic or narrow, and therefore, while the left ventricle is trying to pump blood during systole into the aorta, it's passing through a narrower orifice. So in aortic stenosis, you hear a systolic murmur, but where? Over the aortic area. Notice that when the semilunar valves are stenotic, the murmur is systolic, in contradistinction to the atrioventricular valves that when they are stenotic, the murmur is diastolic. In aortic incompetence, the problem is that at the beginning of diastole, when the left ventricle tries to or starts to relax in order to receive blood from the left atrium, the aortic valve should close completely. But if the aortic valve is incompetent, then some of the blood will backflow or regurge from the aorta to the left ventricle, especially that the pressure in the left ventricle has diminished after the ventricle has pumped all its blood into the aorta. So in such a case, there would be a murmur because the aortic valve did not close completely, and that murmur will be a diastolic murmur. Again, in contradistinction or contrarily to mitral incompetence and tricuspid incompetence. Pulmonary stenosis and pulmonary incompetence will be exactly similar to aortic stenosis and aortic incompetence concerning the timing of the murmur, but the main difference will be in the location or the auscultatory area where you will best hear the murmur. So in case of pulmonary stenosis, the right ventricle is trying during systole to pump blood into the pulmonary artery, but because the valve is narrow and stenotic, then there is a murmur because we will have a turbulent blood flow, and therefore you will hear a murmur that is systolic, meaning that you will hear the murmur between S1 and S2, and there will be, of course, less blood that goes to the lungs as usual, less capillary exchange, less alveolo-capillary exchange, and symptoms of hypoxia. The murmur will be systolic and will be best heard over the pulmonary area. In pulmonary incompetence, at the beginning of right ventricular diastole, when the right ventricle begins to relax and the pressure inside it diminishes, we should close completely that pulmonary valve. But if the pulmonary valve is incompetent, then some blood will regurge into the right ventricle, especially that the pressure will diminish. So the regurge will occur only during diastole when the intraventricular pressure on the right side diminishes, so it would be a diastolic murmur. Okay, thank you guys. This was a short video to finish the arrhythmias and finish the valvular diseases, and you will be receiving a short assignment on those topics. Thank you.